for that very kind introduction. And I just want to say it is my great pleasure. It's my first TIPQC meeting, and I just learned that it's number 17. And I just want to thank our patient, Christina, for sharing her experience. You know, there are so many messages from that story, and we need to hear more and more of those stories. And I also want to point out that the American Heart Association just published a statement on how mental health disorders are associated with cardiovascular disease. So it's very, very important. So thank you for sharing your story. Anyways, without further ado, it's my great pleasure to speak about cardiac conditions in obstetric care. These are my learning objectives, and I have no disclosures. Well, why is this important? What is the problem? What is the burden of disease? I just want to tell a little story, a little background. So in 2015, many of you here in this room know that our very own green journal, the Journal of Obstetrics and Gynecology, published this data on maternal mortality in the United States and how there was a huge rise in the numbers. And when these authors looked at the cause, they illustrated here that cardiovascular disease is number one. This was in 2015. So, and this is before the whole term cardiobstetrics, you know, like Dr. Graves was saying earlier, it's not that these patients came from just recently showed up now that we have this term. This was going on for years. But what's changed is since 2015, many stakeholders across the country joined hands, from cardiology and obstetrics, epidemiology, state officials like we're hearing from today, joined hands to try to do something to change the numbers. And just a few points. So the American College of OBGYN published this practice bulletin in 2019 on pregnancy and heart disease that contains a lot of information, but one of the statements was all women should be assessed for cardiovascular disease in the antepartum and postpartum periods. This is the most recent maternal mortality data, and I think Dr. Alvarado already showed these statistics, but just so you can see that there's been a decrease overall in numbers over the last 2 years, 2022 and 2023. So what are we doing? What are we doing as a nation to change these numbers? Well, you heard earlier about AIM, the Alliance for Innovation in Maternal Health. This is a quality improvement collaborative that many of you are aware of that's supported by ACOG and HRSA. And what they do is they build safety bundles. They built one on hemorrhage, hypertension, pulmonary embolus, and so on. And more recently, in 2023, it was the Cardiac Conditions in Obstetric Care was published. Just a little bit of information about AIM, and what they do is their whole objective is to guide care teams to integrate screening tools and to assure systems are in place for both referral and to support, stabilize, and transfer patients according to what's available locally. Like we could see on the map of Tennessee, there are areas where it may be more difficult to access resources. And finally, to create educational materials for providers and patients on cardiac risk factors, transitions of care, and opportunity for mitigation for future cardiovascular risk. So the AIM bundles, many of you know, are designed by 5 R's: readiness, recognition and prevention, response, reporting and systems learning, and respectful care. Now, respectful care is enlarged purposely to show that there should be respectful care throughout the entire bundle. And I just want to guide all of you, the organization of the bundle, because the purpose of each R is to have associated recommendations. And then when those recommendations to produce tools, the institutions can actually implement and use and hopefully make changes in these national statistics. So what are we doing in New York State, where I'm from? So New York, these are 3-year rolling average maternal mortality. The point of this slide that I really want to focus on is you can see at the very end, 2018, 2020, The green line is New York City, and the rest of the state is that purple line. And you can see that the numbers have come down in New York City, but they've actually gone up in the rest of the state. So what does that tell us? We need to reach out to upstate New York, the more rural areas where there are no hospitals, or, there may not even be an obstetrician for 40 miles. So we're sort of dealing with similar challenges where I come from. These are the different causes of pregnancy-related deaths in the US from 2018 to 2020, and you can see that there have been safety bundles that have matched these different causes. So ACOG District 2, that encompasses New York City, New York State, and the Bahamas, interestingly. Anyhow, we have something called the Safe Motherhood Initiative. And if you look on your phone, you can download the app. And on the app, there are each safety bundle with its associated tools, and you can even follow along these slides to look at the cardiac bundle, and I would encourage that. So in about 2023, kind of similar to when the National AIM bundle came out, we developed a committee that consisted of obstetricians, maternal-fetal medicine, cardiologists, epidemiologists, key state stakeholders to develop our cardiac bundle for ACOG District 2. And that is what I'm going to present here. This is a disclaimer from ACOG. So first of all, how do we define cardiac conditions, right? They encompass many different disorders of the cardiovascular system, which may impact the health of birthing people during pregnancy and interconception, as well as raise the risk of long-term cardiovascular disease. So this includes, as you can see on this slide here, congenital, people who are born with congenital heart disease, valvular disorders that may be acquired from rheumatic heart disease, cardiomyopathies, which are mostly acquired, but there are some genetic arrhythmias. We know that pregnancy really can provoke the most common arrhythmia, supraventricular tachycardia, amongst others. Coronary artery disease, which is really premature development amongst our reproductive age people, pulmonary hypertension, and aortic dissection. So what we did, we decided that really there are three at-risk groups. Number one are the patients with pre-existing cardiac disease. These are the people who were born with coarctation of the aorta, Marfan syndrome, etc. Those folks who maybe had a peripartum cardiomyopathy in a prior pregnancy and now they're getting pregnant again. And those people who have prior cardiac events, so people who had a non-STEMI, a heart attack in the past, or had some kind of arrhythmia. So that's one group. So the second group is the new cardiac diagnoses in pregnancy or postpartum. So these are patients who went through pregnancy and then, surprise, they developed peripartum cardiomyopathy. These are the folks with the hypertensive disorders in pregnancy, the preeclamptics. And then the last group are the postpartum patients at increased cardiac risk. So what we have learned is this terminology, adverse pregnancy outcomes. So the cardiology people are calling pregnant patients with gestational hypertension, gestational diabetes, people who had an intrauterine growth restriction, folks who had a stillbirth. These are adverse pregnancy outcomes. And these patients, the research shows that they are at risk for heart disease when they are in their 50s and 60s, and maybe even earlier. So we developed what we call deliverables. These are tools. So for our first group, we developed tools to evaluate risk, finding the right team, assuring safe care during pregnancy. For the second group, we developed tools to evaluate symptoms, educate other specialties on pregnancy, mainly our emergency room doctors, and postpartum evaluations. Our third group, we developed tools to educate on this APO, adverse pregnancy outcome, and advocate for inter-pregnancy care and lifestyle modification. So just to begin with our first group, just to remind us all, these are the folks with known heart disease even before becoming pregnant. So readiness, train all obstetric care providers to perform a basic cardiac condition screen. We suggested in our bundle tool as screening tool for all OBGYNs to use. Second recommendation, establish a multidisciplinary pregnancy heart team or consultants appropriate to their facility's designated maternal level of care to design coordinated clinical pathways for people experiencing cardiac conditions in pregnancy and the postpartum period. The tools we developed, and I'll show you some of these, a map of cardiobstetric centers. So you can put in your zip code wherever you are, and it'll show you exactly where to go for a cardiobstetric patient. Disease-specific guidelines for cardiac conditions, and a transfer checklist. Moving to the next R, recognition and prevention. Every patient obtain a focused pregnancy and cardiac history in all care settings, including emergency department, urgent care, and primary care. The tool we developed was a preconception encounter tool to guide MFMs or cardiologists who are seeing the patient preconceptually to follow. In all care environments, assess and document if a patient presenting and pregnant or has been pregnant within the past year. Utilize standardized cardiac risk assessment tools to identify and stratify risk. There's the modified World Health Organization risk classification that's one of at least 4 tools that exist to counsel patients on their risk, but it's the one most widely used by OBGYNs. Response, every event, facility-wide standard protocols with checklists and escalation policies for management of people with known or suspected cardiac conditions. So in our toolkit, we have the interdisciplinary team delivery planning checklist, which I'll show. Other reproductive life planning discussions and resources, including access to a full range of contraceptive options in accordance with safe therapeutic regimens. So we show a summary of that U.S. medical eligibility criteria for contraceptive use tool, focusing on cardiac conditions, as well as the bedsider, which many of us in the room are aware of. Response, provide patient education with focuses on general life-threatening postpartum complications and early warning signs, including instructions of who to notify if they have concerns and time and date of a scheduled postpartum visit. So our tool is a pregnancy and postpartum patient education tool and instructions. So these next slides show some of our tools. This is the modified WHO risk in pregnancy. So there are 5 classes, 1 through 5, and they have associated maternal risk for a maternal cardiac event. So if you have a patient in your office who tells you they had a repaired ASD, well, these are patients where the maternal cardiac event rate is about less than 5%, compared to somebody who has a history of peripartum cardiomyopathy and their ejection fraction really hasn't recovered. Their risk is a class 3, which is associated with a much higher maternal cardiac event rate. The other nice thing about the modified WHO is it not only tells you the percent risk for maternal cardiac event rate, and this is based on studies that have been published in the European Society of Cardiology, so that they didn't just come up with these percent rates, it's actually on data. But they also, the modified WHO is nice because not only does it tell you something about risk, but it also provides a guidance of how to counsel the patient, what the recommended care during pregnancy, that they should be seen by a cardiobstetric specialist center, where they should deliver, and the amount of times that they really should see a high-risk doctor. This is a slide of our map. So on the app, a general OBGYN who may be seeing a patient who comes in for the first time and they have a big scar, in their chest, and they ask the patient, what's that from? Oh, I had open heart surgery, 4 years ago, now they're pregnant. Well, that OBGYN that's sitting in rural New York can put their zip code and find, the nearest center where there are specialists to expedite the care that patient might need. This is a sample of our transfer checklist for cardiac concerns that's in our bundle. And I think this is really important. You know, you don't always have time to transfer a patient who's acutely ill, but if you can, it's just a guidance to give your SBAR and, you know, make sure that you have the available obstetric and gynecologic services at your current location, and recognize that there might be a need for a higher level of care and how to effectively communicate when you're transferring the patient so that that hospital can get ready quickly to receive this acutely ill patient. Now, this is a little picture of our meetings that we have every month, and I'm sure many of you here in the room have the same kind of meetings, you know, monthly or maybe even more frequently, where you discuss your patients. And we really started doing this every month, and some months we have to do this more often because we have, you know, a surprise patient who's 35 weeks with a serious cardiac condition. But anyhow, and the beauty of COVID is that now, you know, this is hybrid. We used to sit around the CICU office and meet in person, but now it's really hybrid. People can Zoom on in. And so we have representatives from maternal fetal medicine, the OB delivery team, we've got the OB anesthesiologist there, our cardiologist from congenital heart disease or heart failure. We have L&D nursing leadership on the call. And for certain cases, we might need cardiac anesthesia, the CT surgeons, and the perfusion specialists. And what we do is we sit around, and sorry, I have to mention, the patient is the center of the team. This patient is the center. Without the patient, there is no team. So the patient is our center. What we do is we start presenting the case. Usually myself and my fellow maternal fetal medicine team, we present the patient, we present our obstetric concerns, and finally, we are the ones responsible to assure that this patient is going to be safely managed in labor and postpartum. Then the cardiologist really goes through the cardiac pathophysiology. They go through the echocardiogram, explaining, you know, what's going on with this patient. And the neonatologists are there. They're available to receive the baby. The blood bank confirms that all blood products are available. The L&D OB staff and the nursing leadership are the ones who coordinate one-to-one nursing for the obstetric part, but some of our patients, we request a CICU nurse to be on the labor floor in the same room. So for example, I have a patient right now who has Wolfe Parkinson-White syndrome, but it also looks like she has HOCM, hypertrophic obstructive cardiomyopathy, and so she's somebody who has multiple cardiac issues, and when everybody goes running for the shoulder dystocia, I want somebody to remain in the room watching her volume, et cetera, and watching her for symptoms. So that's an example of where we've been able at my institution at Montefiore in the Bronx, we've been able with nursing leadership to have more than one nurse in the room. The cardiologists and the obstetric anesthesiologists, they oftentimes will ask the cardiologist questions about the pathophysiology, and we come together to go through this form here, which has developed over the years, but it is a checklist that we use. And you know, I'm not a proponent of wasting paper, but I do think that the checklist is really important to get everybody's thoughts on board and to really think about what do we need on the labor floor and what do we need postpartum. Do these patients, when they arrive, do we need to consult heart failure, arrhythmia, etc.? And what medications that we use on the labor floor that are so common do we need to avoid? Do we need to avoid calcium channel blockers or beta blockers? What's our first choice if this patient becomes hypertensive? And if they hemorrhage, if they have uterine atony, can we use Methergine? Can we use Hemabate, TXA, etc.? This is all common for us, OBGYNs, but when we consider the very complex cardiac patient, some of these medications are not okay. Like a calcium channel blocker, you can't give somebody with Wolfe Parkinson-White syndrome, just as an example. Here are some resources for patients that we've included in our safety bundle and that I think are available to everybody. CardioSmart, And here is this is pulled from the medical eligibility criteria and just really highlighting the conditions that are related to heart disease. And you can see that pregnancy puts these patients at much higher risk. So for most of you are aware of this, but just as a reminder, any contraceptive with the number 1 means that it is eligible, it is safe for the patient to take as it's associated with the specific condition. Whereas you can see most of the combined hormonal contraceptives with estrogen we try to avoid, and specifically our hypertensive patients, but also many patients with certain cardiac disorders. All right, moving on to the second group. These are the ones with the developed new heart disease, the peripartum cardiomyopathy patients who are just newly diagnosed. So readiness, every unit, train all obstetric care providers to perform a basic cardiac condition screen. We already said that in the first group, but the tool that we use is a slide deck and outreach to emergency medicine colleagues. So many of these PPCM patients, they don't come to the labor floor, right? They've gone home, they were discharged, they show up in the ED. So the emergency medicine doctors need to be aware. So we provided in our bundle, a slide deck for them. Number 2, establish a protocol for rapid identification of potential pregnancy-related cardiac conditions in all practice settings to which pregnancy and postpartum people may present. Again, emergency department or urgent care algorithms for pregnant or recently postpartum patients we developed, and that's in our toolkit. Establish coordination of appropriate consultation, co-management, and/or transfer to appropriate level of maternal or newborn care. And we have that transfer checklist that you saw. Recognition and prevention. Every patient obtain a focused pregnancy and cardiac history in all care settings, including emergency department, urgent care, and primary care. In all care environments, assess and document if a patient presenting is pregnant or has been pregnant within the last year. Assess if escalating warning signs for an immediate cardiac event are present. So we have in the bundle, I'll ask about pregnancy education. We have the MUSE, maternal urgent warning signs, that is mostly used outside of OBGYN, but we modified it a bit to use in the field of obstetrics. Utilize standardized cardiac risk assessment tools, so our screening tools are in the bundle. And finally, conduct a risk-appropriate workup for cardiac conditions to establish diagnosis and implement the initial management plan. And just a bit about response. Every patient, facility-wide standard protocols and checklists. So this is repetitive. This is associated with the very first group, so I'm going to skip over that. So just to emphasize, the most important questions to ask: are you pregnant? Were you recently pregnant? This really is for the patient that comes through the emergency room. The emergency room doctors, it's very important. Not even the doctors, the people triaging the patient. The patient comes in, has their vital signs. Were you recently pregnant? How long ago? This is a sample of the maternal urgent warning signs. Cardiac symptoms are included: shortness of breath, palpitations, and actually the MUSE exists in 39 different languages. So to end the last group, the pregnancy-related cardiac risk group, the postpartum patients at increased cardiac risk, these are the folks with adverse pregnancy outcomes. And just as a reminder, what that means is people who had pregnancies that were complicated with intrauterine growth restriction, gestational diabetes, that's like 50% of some of our people, right? And preeclamptics, gestational hypertension. So you can see, this is a publication from the Journal of the American College of Cardiology, and they did a study where they showed the different APOs and the risk by odds ratio of developing hypertension, cardiovascular disease, stroke, heart failure, and so on. And it's significant. You can really, really see this here in this slide. And even the Society for Maternal Fetal Medicine published a statement that emphasizes the importance of counseling about cardiovascular or metabolic risks for your patients who have this history of adverse pregnancy outcome. So preconception and interconception are big windows of opportunity to counsel patients about the APOs. And here are the sprinkles of cardiac risk. You can see preeclampsia, hypertension in pregnancy, preterm birth, intrauterine growth restriction, the folks with recurrent pregnancy loss, fertility therapies, gestational diabetes. When we review cardiac risk, take into account pregnancy history, which can enhance the risk. And patients who are otherwise borderline for a risk screen may benefit from statins or interventions if there are risk factors and adverse pregnancy outcomes. So this is from the American College of Cardiology and the American Heart Association. These are guidelines for atherosclerotic cardiovascular disease risk screen by age group. And on the left, you can see risk enhancers, family history of premature ASCVD, persistently elevated LDLs, chronic kidney disease, conditions specific to women, inflammatory diseases. What's missing is the adverse pregnancy outcome. So it's our job as obstetricians, maternal fetal medicine physicians to include that adverse pregnancy outcome and really educate our patients about their lifetime risks. So some resources for patients from the preeclampsia.org association. This is from the California Maternal Quality Care Collaborative, who have done much work with these safety bundles, in particular with the cardiac conditions. And finally, the fourth R, the reporting serious events requires serious discussions. So a post-event debrief for pregnant and postpartum women at high risk for cardiac event, establish a culture of multidisciplinary planning, admission huddles, and post-event debrief, archive debriefing documentation for OB cardiac condition events, and review systematically with unit-specific and QI leadership teams to make improvements for the next one that's going to come through the door. Develop changes and interventions to improve care for the next case. This is an example of how you can create premier perinatal safety initiatives, interventions in a timeline fashion. So the last R is respectful care. Engage in open, transparent, and empathetic communication with pregnant and postpartum women and their identified support networks to understand the diagnosis, options, and treatment plans. Clarify goals for pregnancy as essential to include in a patient's treatment plan. Refer patients who've experienced significant cardiac events for trauma, including these support groups. We heard about that from our patient earlier who spoke about her journey, about how important these support groups are. So for example, there's a SCAD Alliance, and there's several different support groups for patients with peripartum cardiomyopathy. And this is very, very, very important for these survivors. Include each pregnant or postpartum woman and their identified support network as respected members of and contributors to the multidisciplinary care team. Ensure that a qualified network of interpreters is identified and utilized to support and facilitate patient communication. Very, very important. So here are a couple slides on respectful care at birth. This is all in our toolkit. And the share approach, very important to have shared decisions. So often we'll have a patient that comes in, they're in their first trimester and they have this really tough history of aortic dissection. I'll just pick a really tough one out there. And it's really our responsibility to walk that patient through the risks of pregnancy, but also to hear their desire to create a family and their desire to have a baby. And we have to really try to walk them through that journey and make sure it's safe. Screen for birth trauma, not only for your patient, but also for the partner. So that completes my presentation on the cardiac bundle that we produced for ACOG District 2. And it's really, we pulled those recommendations from the National Cardiac Conditions in Obstetric Care that it sounds like you all here in Tennessee are also utilizing. So you probably recognized a lot of those recommendations. I just want to end with a little bit of what I've been doing at Montefiore. So just a little history here. You know, this is what our office looks like in the Bronx. So it was 2015, and well, actually, backing up, is 2012. I went to Montefiore Einstein right out of fellowship, and I came from California, from Harbor, UCLA, where I'd seen a lot of cardiac cases. You know, I thought it was interesting, but I didn't have my career set on doing that. I actually wanted to do global health. But anyways, so during my first week on service at Montefiore, I was taking care of a patient, a 21-year-old who was in heart failure, and she was only 10 weeks pregnant. Turns out she had something called Takotsubo's cardiomyopathy. Anyhow, I met Dr. Bortnick, who was also right out of fellowship. She's an interventional cardiologist. And she and I started talking about how shocking it was that this patient was so sick, so young. And we, you know, it took us 2 years, but over time we spoke about how we really need to capture these patients earlier and talk to them and counsel them and care for them, seeing them together in one room. And finally, in 2015, it was just kind of a coincidence that we started our program February 2015, a month after that publication in our Green Journal, where we started seeing patients together, examining them together and talking about them. And it's built over the years. We had an imaging specialist join us, Dr. Taub, Dr. Zaidi, a congenital specialist, Dr. Cohen, who's now retired, a general cardiologist, Dr. Su, congenital. Many of these people have retired since, but these are just the people who've contributed over the years. Another echo specialist, Dr. Trivedi, Dr. Foreman, a general cardiologist, Dr. Chavez, a heart failure specialist, Dr. Haberer, a congenital specialist, Dr. Murthy, pulmonary hypertensive and heart failure specialist, Dr. Zhang, a cardio-oncologist, and Dr. Gupta, a congenital cardiologist, and Dr. Jayufar, a heart failure specialist, and then there's me. So over the years, we've really been able to join hands. You can see this is a table that you may not be able to see clearly from where you are, but what I want to show here, these are our numbers since 2015. We started out seeing 61 new consults in a year. This doesn't include our follow-ups, and all the way up to the 200s. You know, our most recent data, our patients, the consults have really increased. And over the years, we've had about 30% of our patients congenital patients, maybe another 10 to 15% cardiomyopathy, 10% arrhythmia, a few valvulars in there. But the patients who the section that's really grown, you know, here I have to change this slide because it says benign. These patients are not benign. These are the ones who came in, were referred for symptoms, palpitations, shortness of breath, or they had preeclampsia, you know, something strange happened peripartum, they desatted, they had pulmonary edema. These are the patients who are at risk down the road. These are the ones with a lot of cardiometabolic diseases, and I'm happy that now 50% of the referrals are these patients at risk. And I think that this is really where we can make some significant change. They may not have heart disease in that pregnancy, but if we could do something interconception to prepare for the next pregnancy, or if we could do something to mitigate their risk when when their kids go to college and they're empty nesters, I really think that that's a place for improvement. And in 2024, here's 2023, we have about 30, throughout the year, we created about 30 delivery plans for our patients that are available in the electronic medical records, so everybody's on board. And really, a huge shout out to the nursing leadership at my institution for making some of these delivery plans go really smoothly. And I just want to share a few other things that we've done. We've had so many presentations from fellows, residents at Society for Maternal Fetal Medicine, and another international conference called Cardiac Problems in Pregnancy that meets about once every 2 years. And these are just various abstracts and case reports that we've joined hands. And in this slide, it's a nurse practitioner on the left, a cardiac nurse practitioner, myself, an MFM fellow, and a cardiologist. So it is really team work. This is another fellow and I that we went to the American Heart Association, another fellow who presented a case report at the Society for Maternal Fetal Medicine. And here are some screenshots of Zoom case presentations of another fellow who presented this case. And we also, every year, we have these annual CMEs. We started this in 2017 with the support of my chair from the Department of OB/GYN and the chair from cardiology, who help provide funds. It's a dinner in the fall where we have about 5 presentations, and we talk about updates on cardiac conditions in obstetric care. And we've been able to keep this up even during COVID. Actually, during COVID, we had it around the world. We were able to invite people from all over the world to present. And what this has really done is it has provided awareness within our community. We actually had this patient here on the left lower, the far right. That is a patient, a heart transplant patient, and her husband who joined us. And this patient in the middle is a survivor of cardiomyopathy. So they've come to our meetings, and it's a lot of fun. The last thing I want to show, this is our heart transplant patient who made it to the news. This is her pediatric cardiologist on the far left, and then her heart failure doctor on the far right. She did great. She had a vaginal delivery and is enjoying family life. And the last thing is we started the institution of point-of-care ultrasound training amongst our MFM division to try to identify heart and lung abnormalities on the labor floor and in the PACU. This is something we're still working on, trying to provide a curriculum. This is the cardiovascular screening toolkit that Dr. Graves and I have been involved with, and I think you have here in Tennessee, where there's universal screening for all pregnant and postpartum patients. And over 2 years' time, we've screened at least 3,000 patients, about 300 screen positive. 100 of them have come for their consult, and at least 40 were found to have true heart disease. So we need to continue work, join hands, nursing, NICU, anesthesia, cardiology, blood bank, CT surgery, patient safety. And I just want to end this talk by saying it takes a village, it takes a team. I could never do any of this on my own. And just a huge shout out to everybody here for being here, and I look forward to sharing with those of you who are interested. Thank you.